confusing things of this tiny topic, and it's not that confusing, is how to really differentiate between primary and secondary amenorrhea, because they seem to share a lot of the same features. So like if we just pay a quick visit, let me just get rid of these little lines I forgot to take off last time. But if we just pay a quick revisit to primary amenorrhea, so that should be right here. So this was the absence. It was two different criteria here. It was either the absence of menses by age 15, but secondary sexual development was good, or the absence of secondary sexual characteristics by age 13. And at this point in this person, where the absence of secondary sexual characteristics has occurred by age 13, this person also doesn't have menses, by the way, right? So they both have absence of menses, both criteria, the absence of menses in both of them. But if you're age 15 and you don't have menses and you don't have secondary sexual characteristics, then that isn't amenorrhea, right? If you're 15, there's no menses and there's no secondary sexual development, that's not amenorrhea. That's completely a different topic, because at that point this person may not even be a girl, right? And the problem would be something you would have to look into a lot more. Or if you're age 13, have no menses, and you don't have secondary sexual characteristics, that's also something of very different concern. Right, so these are the main things they wanted to talk about for primary amenorrhea, along with, of course, delayed puberty. And they mentioned some of the etiologies, some of the reasons that you can get it, but all the different reasons they mentioned, congenital adrenal hyperplasia, or the ones right here with the ovarian insufficiency, a central hypogonadism where the brain isn't making LHF stage and all those things. Those were the ones that they are listing out as primary amenorrhea, whereas secondary, you can see, shares some of them, like the ovary one. But here it's not that it's not just that there's ovarian failure or anything like that. These are people with other conditions. So that's the number one differential right there. So the person who has amenorrhea, the girl that's coming in with amenorrhea, if she has other conditions that are causing the amenorrhea, then it's secondary, right? Which makes sense. That's why you call it secondary. The amenorrhea isn't primary, because it's not just that something is causing her to not have menstruation. Uh, she just doesn't have menstruation because of some primary things that are directly related to menstrual cycle, like either the menstrually hormones related to the menstrual cycle are not working, or some functional unit of her body that is related to the menstrual cycle is not working. But in these people, there are in secondary amenorrhea patients, there are specific conditions that are causing the entire menstrual cycle to not work, right? So PCOS, really bad systemic illness, pituitary adenoma, and then of course hypothyroidism is always a thing. You always need to check for TSH. And then here there's one condition, uterus having Asherman syndrome, which is actually in this question as an example, right? So there could be uterine causes for primary amenorrhea also, where maybe the uterus is just not able to grow correctly, and it could be due to nutritional deficits, right? But then here in secondary amenorrhea, the uterine cause is an actual condition. And so that's the difference between primary and secondary amenorrhea, which was pretty critical to differentiate, just because you will need that in terms of picking answer choices, or no, well, of course picking answer choices, but picking answer choices related to what the next best step would be. And so if we look at this patient, her condition, basically 32-year-old woman, comes to the office for evaluation of absent menses. She had a vaginal delivery 4 months ago, and she has not had a menstrual period since delivery. Her postpartum course was complicated by a postpartum hemorrhage requiring blood transfusion and emergency suction and sharp curettage. At her postpartum visit 2 months ago, she was started on combination oral contraceptives and has had no vaginal bleeding or spotting during her week of placebo pills. Prior to this pregnancy, she had regular monthly menstrual cycles with 3 to 4 days of moderate bleeding. She has had increased fatigue since returning to work and is bottle feeding. She has no headache, lactorrhea, or hot flashes. Vitals are normal. BMI is overweight, right? So she's obese. Anything on step 1 that's over 30 or over, even 30 counts for most conditions, then you consider that for step 1 purposes someone that is obese. Pelvic exam shows clear vaginal discharge throughout the vault and a well-rugated vagina. The uterus is small and anteverted, and there are bilateral small non-tender ovaries. Urine pregnancy test is negative. FSH and TSH are also normal. So what's the most likely diagnosis for her? And just by reading the question, you don't really catch anything in the question that's significantly bad, right? You don't see anything in the question that's like, wow, that's extremely concerning, huge red flag symptom, nothing like that per se, right? The primary issue she has right now is her absent menses, but she's 32, she's always menstruated just fine. The only new thing in her life was that she had a vaginal delivery. So that means that something must have occurred in the vaginal delivery that led to her now not having menstruation. And the two things that could really occur after related to a delivery that leads to lack of menses are these two answer choices. So the 30% of people that chose Sheehan syndrome were not completely wrong in picking it, but there was one part that kind of proved that wouldn't be the problem, and that was because they told you FSH is normal, right? FSH and TSH are normal. TSH is normal, that's fine, but Sheehan syndrome is where your pituitary doesn't work anymore, right? That's pituitary just dying because of lack of blood supply. So if your pituitary is not working, then FSH would be low, right? So this last sentence right before asking the final question kind of got rid of that answer choice. There was no way, right? But now that's step one. Step one, of course, tells you a lot of information. You can actually even ask this question without really putting this statement there, right? Remember when we did NBME exams, we always said that it looked like they took this UWorld question and just chopped out some sentences and made an NBME question, right? That way there's no copyright issue, and it's perfectly a brand new question. So if you have absent menses, you just had vaginal delivery 4 months ago, haven't been menstruating at all since delivery, postpartum course was complicated by a postpartum hemorrhage. So now we know what could have been the key cause. Postpartum hemorrhage causes Sheehan syndrome because you lost so much blood you couldn't supply blood to the pituitary. So she got blood transfusions. She also got a suction and sharp curettage, right, for cleaning up the hemorrhage. And then 2 months ago she was starting on oral contraceptives, which is fine. That doesn't do anything. That's just she needed it, but it doesn't do anything for the main issue in the question. That is something they throw into questions to just throw you off, right? Because there was probably also an answer choice related to oral contraceptives. And has had no vaginal bleeding or spotting during her week of placebo pills, right? So she's not even taking real stuff yet. Prior to this pregnancy, she had regular monthly cycles. Everything was okay. Now they start telling you some symptoms, which, telling you FSH and TSH is normal was great, but you didn't even need that. They told you she has no headaches, no galactorrhea, and no hot flashes. So the galactorrhea isn't even there, right? She doesn't have galactorrhea, which would occur if she was releasing a lot of prolactin from maybe a pituitary prolactinoma or something. And she doesn't have hot flashes. That means that her hormones are all working fine. So if all the hormones are working fine, I don't need to spell it out for you in the end of the question that FSH and TSH are normal, right? But UWorld is going the extra step to really tell you the answer. They do this in some questions, actually in most questions. Almost all questions on UWorld go the extra step to really lay out the answer for you. And if you got it wrong, it's because you hadn't learned it yet. But then when you finish learning it, you'll see in the explanation, they're like, yeah, these were the 50 different points we made in the question that are pointing at this answer choice. And then you learn that those points are things that point at the correct answer choice and how. So here, since everything is fine hormonally, it couldn't be Sheehan syndrome. So it must have been Asherman syndrome. There must have been something you did in the uterus with the suction and sharp curettage that kind of messed it up, right? So she has Asherman syndrome, the formation of intrauterine adhesions that can follow intrauterine surgery, such as emergency suction and sharp curettage. Asherman syndrome occurs commonly after suction and sharp curettage, especially the sharp one, not just a dilation in curettage, not a DNC, but a suction and sharp curettage. If you ever do a question and they mention this, then you want to think of Asherman syndrome. Such as postpartum hemorrhage and endometritis, because the postpartum uterus is soft, enlarged, and more prone to aggressive curettage. During this procedure, the bacillus layer of the endometrium can inadvertently be injured, creating a denuded adherent intrauterine surface prone to synechia and endometrial cavity obliteration. Because of complete or partial obliteration of the endometrium, patients typically develop very light menses or secondary amenorrhea that does not respond to a progesterone challenge. as evidenced by no withdrawal bleeding during the placebo week of oral contraceptives. Right, so this entire thing, they mentioned how she was started on combination OCPs and then had no vaginal or spotting during her 1 week of placebo pills, which is basically the progesterone withdrawal test. Remember, the progesterone withdrawal test is extremely high yield, and there's many ways to test you on it and many ways to even mention it in a question. This is how they're mentioning it in this question. There's one very sneaky way of mentioning it. You gave somebody oral contraceptives and then you gave them placebos. Why would you do that? That's the progesterone withdrawal test, right? When you gave the placebos, you basically withdrew the progesterone in the oral contraceptives. So progesterone withdrawal test didn't cause any bleeding, so then that's obvious, right? If you do the progesterone withdrawal test and there's no bleeding, like this over here on the right side, then usually the answer is low estrogen. But in her specific case scenario, it's not that she has low estrogen. Why is it not that she has low estrogen? Because she doesn't have hot flashes, right? Low estrogen and menopause and stuff along those lines usually cause hot flashes symptoms, but she actually just has an endometrium that isn't developing at all. And that must be the other thing that you can obviously see in this picture, an endometrium that doesn't develop at all compared to here. One of the major reasons endometrium development can be halted is low estrogen. The other thing is many other things, but this one in her specific case scenario was Asherman syndrome because of the curettage she got. Right. So that's basically all this question was, but it was a very nice question, not just because of the breakdown of mistakes, with the 30% of people choosing another viable answer choice, but it wasn't that viable at all. And then the way they mentioned the progesterone withdrawal test here, so it was a very good question. Let's see. And then now we're moving on to dysmenorrhea. So dysmenorrhea is painful menstruation, and menstrual pain associated with ovulatory cycles in the absence of pathologic findings. So it's primary if there's no pathologic findings, and then we'll see secondary later on. Caused by uterine vasoconstriction, anoxia, and sustained contractions mediated by an excess of prostaglandin. They have a little question, well, two questions here on the book itself. The first one says, a 56-year-old woman presents with complaints of insomnia, vaginal dryness, and lack of menses for 13 months. What is the most likely diagnosis? Well, she's over 51, so this must be menopause, right? And then over here, 16-year-old girl presents with decreased appetite, insomnia, and amenorrhea for 3 months. So pretty much the same symptoms. What is the most likely diagnosis, and how will you confirm it? Well, a 16-year-old girl, having amenorrhea for 3 months, the first thing you would want to do for her is definitely a pregnancy test. But then the decreased appetite part and insomnia should lead to more thoughts. So if we look at the answers now, the most likely diagnosis is menopause for the first woman, right? Completely made sense because she's over 51 and it's been over a year since she menstruated. So that's standard. And then here, pregnancy. You see, confirmed with the beta ACG. The thoughts should be very straightforward. Now, most students that I ever did this with, throughout the book questions that there are in the book itself, most students that I've done these questions with tend to panic when we're going through notes and we're studying through a quick chapter, whatever chapter you might pick. These questions that are in the book itself are throughout all the chapters. So maybe we're doing like we are together doing right now, primary dysmenorrhea. I'll stop and I'll be like, all right, let's take a look at these quick questions and tell me what you think. Almost all students panic and they don't really have a quick, solid answer, a confident answer. Those are signs of like you're new to this, you have no idea what's happening, and of course that could be a student who's brand new. If the student is brand new, that's perfectly fine. If the student is not brand new, done with step 1, right, then these answers should not be too difficult. Right, done with step 1. I'm not even saying step 2 ready. These are step 1 questions, if anything, at the very least. And you want to make sure that these are the kinds of questions that you can kind of really just solidly evaluate in your mind without having to think too much, right? Because these, of course, one of the things that make students panic is that these questions don't have multiple choice here, right? There's no answer choices here. But then they didn't really need it because specifically these two questions are very straightforward and very easy. Super obvious positions. You always want to think of the most likely case scenario that could have occurred and the easiest way to test it. The quickest and easiest and cheapest diagnostic test you can make is the key thing for CK. So these were really nice and straightforward. And again, like if you did struggle with it, if you ever see questions that are in the book itself and you find it a little like, oh, you didn't think of what to do, then those are signs that you should continue to evaluate, those specific topics, and kind of develop a better mentality of like, what should you be thinking when you see this kind of patient. If I get a 16-year-old patient coming in telling me she hasn't menstruated for 3 months, I'm immediately thinking she's pregnant, because 16, she must be having sex, and now she's pregnant, right? And that too, unsafe sex. Must be having unsafe sex. Similarly, 56-year-old woman comes and tells me she hasn't menstruated for 13 months. I don't care about the other symptoms, right? If a 56-year-old woman hasn't menstruated for 13 months, the first thing I'll think of is menopause. Then I'll, look for other symptoms and make sure it's not anything else. But it's not that far-fetched to think that a 56-year-old woman is menopausal. Of course she is. I hope she is, because it would be pathological to still be menstruating at age 56. And plus, imagine that, for menstruating for that many years of your life. Like, you kind of want to get over it at one point, right? So you also want to learn to not be further confused and intimidated by extra things the question may have mentioned. Both of these questions mention something that may have made you stop and think a little extra for no real reason. The first question mentioned insomnia, right? And this question mentioned decreased appetite. Those two things, right? Insomnia is far from menopause and may have thrown you off a little bit into thinking of some other pathological issue. And here, same thing, right? The decreased appetite may have made you think of all kinds of weird things like bulimia or anorexia or something stupid. And it's completely logical for it to happen. Those are the mind games that even New World plays. They'll tell you all kinds of extra shit in the question to really make your brain wander off into different directions, even though you may have initially been on the right road, right? Questions always have forks in the road, and those are the forks you don't want to take. You don't want to take the wrong path on that fork, right? You're always going to have to take a road from the fork, but you don't want to take the wrong path, right? So insomnia was something you could just ignore. Why does she have insomnia? Well, she's getting hot flashes all night. That's why. So she's unable to sleep. She's probably burning up all night. Same thing here. Why does she have decreased appetite? That is actually because she's pregnant. It's been 3 months now, and she's probably having morning sickness a lot. So those are some things to kind of consider there. Now, coming back to here, so menstrual pain. So let's take a look at what they tell you here. History: presents with low midline spasmodic pelvic pain that often radiates to the back or inner thighs. Cramps occur in the first 1 to 3 days of menstruation and may be associated with nausea, diarrhea, headache, and flushing. No pathologic findings, right? That's the key thing for primary dysmenorrhea. Secondary dysmenorrhea will have pathologic findings. This is very much just like primary amenorrhea and secondary amenorrhea. When you're not menstruating, there's no periods, but it's because of things that are directly related to periods, then that's primary amenorrhea. But if you have lack of menstruation due to some other disease, that's secondary amenorrhea. Here, primary dysmenorrhea is just having periods that are causing pain, but not because of any other disease, right? Not because of any other really bad pathologic finding. And then in secondary dysmenorrhea, we're going to see conditions that can cause, you see common causes are actual diseases, right? Endometriosis, adenomyosis, fibroids, adhesions, pelvic inflammatory. None of that should be there here in the primary dysmenorrhea. A diagnosis of exclusion: rule out secondary dysmenorrhea first, and if you rule out secondary dysmenorrhea, then it must be primary dysmenorrhea. That's how you diagnose primary dysmenorrhea. So now this becomes anytime there's a diagnosis of exclusion, it becomes a very complicated and very testable topic for one really good reason. If you're thinking that someone has primary dysmenorrhea, the only way to diagnose it is to try diagnosing them for secondary dysmenorrhea. If you try diagnosing them for secondary dysmenorrhea and you fail, then it's primary dysmenorrhea. But now, see how to diagnose primary dysmenorrhea, you have to know secondary dysmenorrhea really, really well. And that's what makes these questions very, very hard, because then in that case scenario, you're going to have to wonder which one of these secondary dysmenorrhea causes does she possibly have, and how do you test each one of them. That's what ends up often making these questions very difficult. And there's only one way to really get good at it, and that's with practice. And we're gonna see that right now. So if you are able to correctly diagnose primary amenorrhea by ruling out primary dysmenorrhea by ruling out secondary dysmenorrhea, then you simply start treatment with NSAIDs. And that's the answer you'll be picking. Just give the patient NSAIDs. You could do topical heat therapy for symptomatic improvement. You could do combined hormonal contraception or progesterone intrauterine device if necessary, if the periods are too heavy. Right? So here is a question where it is primary dysmenorrhea. So let's see what's happening. 16-year-old girl, okay, comes to the office for evaluation of painful menstrual periods. Great. So you know from the first sentence the question is about dysmenorrhea. She underwent menarche at age 13 and initially had irregular menses, which is perfectly fine, that's totally normal. Her menstrual cycles now occur every 30 days with 4 days of moderate bleeding. Her menses have become increasingly painful. Lower abdominal pain starts a few hours prior to menses and lasts 1 to 2 days with associated fatigue, dizziness, and diarrhea. Well, that's pretty weird. She misses school at least 1 day per month due to pain, but is able to maintain her grades and has no pain or other symptoms after completion of menses. So basically what they're telling you is this dysmenorrhea is so bad that it is actually messing up her functionality, right? Because she's missing school. 1 day a month is a lot. Usually in a year of in one school year, you'll probably miss like 3 or 4 days tops. One day every month is too much. She has a history of depression. Okay, so now here comes the forks in the roads, right? You got to get really good at identifying them. These forks in the road, some of them could be the right path, some, and then of course, like, you know, every road, if it forks, you're gonna have to take the fork no matter what, right? And then this could fork again, you're gonna have to take the fork no matter what. It's not like you can get off and make your own path, right? So now the lesson is, did you take the right path from that fork? That's what we're trying to learn right now. So this depression thing could be one of the paths that is leading to nothing, right? This is leading to nothing, this is leading to nothing. This one might be the one that leads to the answer. You want to make sure you take the right path, and how you do that really depends on whether or not this path was necessary. Like, it's okay if you took this path, you can always come back and go the other way. So that's what you need to be good at, right? So is it critical that she has depression? It could be, because we know that there are some medications that you could take for depression that could mess up your menstrual cycle. So she has a history of depression for which she simply sees a therapist, right? But has had no recent changes in mood. So that's pretty good. They didn't say that she takes any medications. So that's basically a sentence we could just completely delete because it seems like a completely useless one. She recently became sexually active. So she is sexually active, okay? And uses condoms for contraception. Her last menstrual period was a week ago. So now, you know what? We can actually delete this entire shithole right here. You know, we can just get rid of this, because all of this entire list of things right here is basically stuff that was irrelevant, forking in the road. Right? Just mentally think of it like that, because these are lines that the UWorld question writer is adding just to throw you off. Right? It was completely unnecessary, because none of them actually led to some kind of meaningful purpose for us as physicians. It didn't help me evaluate her at all. You know, nothing pathological came out of it. It told me some normal things that I'm glad are there for her. The normal, she uses contraception, she has her menstrual period still working just fine, her mood is okay, but none of those are pathological things that are helping me take myself to a diagnosis. Vitals are normal. Pelvic exam, now this should be the part that gives it away. It's always the physical exam of some sort, neurological exam, pelvic exam, depending whatever chapter you're in, that gives you the answer. So here, pelvic exam shows normal external genitalia and a clear discharge emerging from the cervical os. On bimanual exam, so here's another part of the same exam, the uterus is mobile, non-tender, and normal in size and contour. Bilateral adnexa have no masses or tenderness. What is the most likely diagnosis? So now, you see what's happening here compared to most questions. Remember that primary dysmenorrhea was a diagnosis of exclusion. So to diagnose primary dysmenorrhea, you had to rule out every single thing that could cause secondary dysmenorrhea, which is what makes any diagnosis of exclusion very hard, because now you have to rule out every single freaking problem out there that could cause secondary dysmenorrhea, and that's what they just did, right? So as I was saying that you could usually cut out these lines, well, not entirely for primary dysmenorrhea. In any other question, any other type of question, when they tell you, oh, this is normal, that's normal, A is normal, B is normal, C is normal, all these things about her are normal, we usually don't care. You know, we don't care, because it's not really leading us to what is actually the problem with her. But with this issue of dysmenorrhea, it is the list of things that is normal that actually leads you to the diagnosis, because all those things being normal are ruling out the problems of listed things for secondary dysmenorrhea, right? The fact that her bimanual exam has a uterus that is non-tender and normal in size means she doesn't have endometriosis. The fact that their bilateral adnexa has no masses or tenderness, her ovaries are normal, right? The fact that uterus is completely normal in contour, there's no fibroids, right? So we just ruled out every single other cause that could have caused her to have one of these things: endometriosis, adenomyosis, fibroids, adhesions, PID, and many other causes of dysmenorrhea that could be secondary. And that's what this question was doing. After they ruled out all these things, and you see everything that's normal, perfectly fine, not a single thing in this question was, oh, by the way, she has X, Y, and Z. No, nothing like that happened, right? There was not a single red flag thing in this entire question. Everything either canceled each other out, like having depression by getting a therapist, cancels it out. Similarly, when they tell you in a question someone has hypothyroidism and they're taking levothyroxine, that cancels that whole sentence out. Because if you are hypothyroid but you're taking levothyroxine, then you're not hypothyroid anymore. You're functionally normal. Right? Similarly, that kind of thing always happens. And in dysmenorrhea questions, in any question, any topic of exclusion diagnosis, you want to make sure everything is perfectly normal. It was only because everything in her is perfectly normal, the answer is primary dysmenorrhea. At the onset of menarche, adolescents typically have irregular, non-painful menses due to lack of ovulation from an immature HPO axis. So her having irregular menses initially was perfectly normal, and we've already talked about that before. As the axis matures, ovulation can cause excessive endometrial prostaglandin release during menses, which results in lower abdominal cramping and other associated symptoms. So what's the main cause here? Prostaglandin release, which we saw. Right, we saw it right here. They tell you excess of prostaglandin. Right, main causes of primary dysmenorrhea could be uterine vasoconstriction, anoxia, and sustained contractions from prostaglandins. Her case scenario, they're telling you, is due to prostaglandin release during menses. Right, other associated symptoms like fatigue, dizziness, and diarrhea can also be there, but she had, right. That was the only thing that I actually underlined in her list of things, because I was like, why does she have diarrhea? Like, you don't usually. I mean, I don't know if women know more, like, women are the ones actually going through this, so maybe women have experienced this, so they might know. But as a man, I had no idea that there's some relation of diarrhea with menstruation. When I first saw this question and typed it into the book, it was very interesting to see that. So that's how we learn. And that symptom was the only thing I underlined because it felt a little out of place. But now we know that it's because the excessive prostaglandins in her dysmenorrhea case that is causing it. Other than that, primary dysmenorrhea is common in adolescents. Patients typically have crampy bilateral lower abdominal pain, can cause her to miss school, which was really problematic. Normal pelvic exam, no chronic pain symptoms, everything should be normal. That's how you rule out secondary dysmenorrhea, and then just treat her with NSAIDs, which are anti-prostaglandin, right? In sexually active patients such as her, combination oral contraceptives are an option since they suppress ovulation, thereby providing contraception as well as decreasing prostaglandin release, right? Most women have decreasing symptoms with increasing age, and primary dysmenorrhea is not malignancy. It's not, so it's obviously not malignancy. It's not a cancer, but it's not extremely problematic. It's not a huge issue, right? Because it will go away, and you can easily treat it with a very safe medication of just taking NSAIDs. So now we can look at secondary dysmenorrhea. Menstrual pain for which an organic cause exists, like one of these things. Patients may have a palpable uterine mass, cervical motion tenderness, adnexal tenderness, or vaginal cervical discharge. However, normal abdominal and pelvic exams do not rule out pathology. But this is basically what they did in our other question with the primary dysmenorrhea. They checked for each one of these things, and she didn't have any of these things, so the answer was primary dysmenorrhea. But if your patient has some symptoms that are concerning, then you further want to investigate one of these things, right? So there's a table below now for distinguishing each one of those things, mainly the endometriosis versus adenomyosis, which are both step 1 topics. And that's basically all they're going to do. So right here, we're gonna go to the step one book to look at it a little more because we learned it even better here, and there's far better notes for all of it. So not the tumors, not the cervical pathology, but mainly the these things. Right? So uterine conditions, adenomyosis, Asherman syndrome, which we just looked at, fibroids, endometrial carcinoma, endometritis, endometriosis. All of these conditions, all these uterine conditions, are things you have to know very well and how to differentiate them all, right? And then of course there's a bunch of pictures in this right here to show you how it all looks like. So we'll come back to here after we look at it real quick in the CK book. So first thing they talk about here, difference between endometriosis versus adenomyosis. These are two completely different conditions. Endometriosis is where functional endometrial glands and stroma outside the uterus, right? So endometriosis, basically your endometrium is going places, right? So your endometrial glands have moved from the uterus to other places. Adenomyosis is where endometrial tissue in the myometrium of the uterus. So now the glands, anything glandular is usually adeno, right? So the endometrial glands have moved into the myo, right, into the myometrium. It's in the name. So that's kind of what I'm trying to show you here, right? So endometriosis is endometrium going places, and adenomyosis is the glands of the endometrium going into the muscular layer, right? So we can see that in these pictures right here. So see, like here we see adenomyosis. So you see how the glands have moved into the muscle. That's not how it's supposed to be. This is normal, right? And the endometrium should just stay on the endometrial layer. The myometrium should be just muscular. But here you can see the endometrium has moved into the muscle. So that's all adenomyosis is. And then here we're seeing endometriosis, where the endometrium has moved into many different places, right? You can see there's a part on the bowel here, right? This would be your large intestine. There's a part here on the bladder, right? There's the implants and adhesions outside the uterus, all over the place. So that's really not normal, of course, right? So those are the main conditions we're looking at. So if we look at endometriosis first, cyclic, so history and physical exam are going to show cyclic pelvic and or rectal pain and pain with sex, uterus not enlarged but painful nodules, restricted range of motion, right? The uterus, as you can see, we're looking at endometriosis. It's not going to cause the uterus to get bigger. It's just that things from the uterus have moved to other places, but the uterus itself is still the same size, doing the same things it was always doing. Nothing brand new about that, right? So that's going to be really critical, because now if you compare that to adenomyosis, you can already see from the picture here that this thin muscular layer got fatter, right? So classic triad of pain, amenorrhea, and an enlarged boggy symmetric uterus. Boggy because it's full of blood all over, and symmetric, which is going to help you differentiate from fibroids, which is going to ruin that symmetry because there's more fibroids on one side or the other, or it's going to cause little bumps, right? So this is symmetric, boggy, enlarged adenomyosis. The physical exam is going to be extremely critical in you figuring out the answer. For endometriosis, diagnosis requires direct visualization by laparoscopy. Classic lesions have a blue-black, raspberry, or dark brown powder-burned appearance, and the ovaries may have endometriomas, which are chocolate cysts. Right? So everywhere it goes, it makes these dark things. This is what they're talking about. And it can also go all the way to the ovaries and cause dark cysts over there. Chocolate dark cysts. For adenomyosis, diagnosis requires an MRI. Right? MRI can aid, but then that's very costly. So ultrasonography is useful, but cannot always distinguish between leiomyoma and adenomyosis. Ultimately, a pathologic diagnosis where you would have to take a biopsy. Right? Treatment of endometriosis is to inhibit ovulation. Combination hormonal contraception is first line. GnRH analogs like leuprolide are also heavily tested on STEP. Danazol, NSAIDs, or progestins can also help. Conservative surgical treatment would involve excision, cauterization, or ablation of the lesions and lysis of the adhesions. Right? You would have to basically go in and get rid of all of these things. But the ones you really need to get rid of are the ones that are causing these spiderweb adhesions. Right? Those are going to be problematic and can cause other parts to stop working. 20% of patients can become pregnant subsequent to treatment. 80% cannot, so that's problematic. Definitive surgical treatment with lysis of adhesions is going to be the final answer choice, right? Which you would have to go for if things are becoming really problematic. But as you can see, one of the complications is the 80%, right? Infertility, the most common cause among menstruating women over age 30, right? And infertility is a very high topic. So if you have someone who has infertility, but everything's fine, they're menstruating, blah, 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 then it's probably because they have endometriosis that cause all kinds of functional issues. For adenomyosis, treatment involves symptomatic relief. NSAIDs are the first line, plus combined hormonal contraception or progestins. Conservative surgical treatment would be ablation, resection using hysteroscopy. Complete eradication of the deep adenomyosis is difficult and results in increased treatment failure. Right? You really can't do too much in terms of like how are you going to get all this out? You can't. It's just spread into the muscle now, and it's just going to be there. Right? So that's why it's just mainly symptomatic relief with NSAIDs. You can't do anything else about it. Right? Definitive surgical treatment would just be hysterectomy, but then if you do a hysterectomy, she can't get pregnant. So if they're done having kids, then hysterectomy is the way to go. Right? May very rarely progress to endometrial carcinoma, which of course you want to avoid. Right? So that's kind of what we were looking at in these two case scenarios. Now, if you look at fibroids, you can see how it's gonna be very obvious on physical exam, right? You're gonna be able to tell the asymmetry, and you're gonna be able to feel some of these. And fibroids get tested in many unique ways. For example, one of these fibroids can be sticking out on the other side, behind what we're looking at right now. And remember what's behind, that's the rectum. So the fibroid can actually compress the rectum in the back and cause constipation. So that's another way it often gets tested. If we look at these questions that are right here real quick, these three. So 42-year-old woman, G4P4, so she's been pregnant 4 times, comes to the clinic due to heavy and painful menstrual bleeding over the past 3 months. Her last menstrual period was 4 weeks ago. Menarche was at age 10. Menstrual periods last for 3 to 5 days and occur every 30 days. So far I've seen one thing that's a problem here, which is the menarche was really early, like really early. She's sexually active with her husband, does not have pain with intercourse. She had a bilateral tubal ligation 3 years ago after the birth of her last child because she didn't want to get pregnant anymore. Okay, that's great. She takes no medications, has no allergies, BMI is fine, vitals are normal. On bimanual exam, the uterus is uniformly enlarged. Urine beta HCG is negative, so she's obviously not pregnant, and she shouldn't be. Biopsy shows a secretory endometrium. What is the most likely cause of her symptoms? So, if her endometrium is very secretory and her whole uterus is uniformly enlarged, then the only answer to go with is endometrial tissue in the myometrium. This is adenomyosis, like this. Right? The whole uterus is symmetrically enlarged, and of course the whole thing has basically become a gland, so it's very secretory. That's what they're telling you here. So 43% of people chose that. 22% chose hyperplastic growth of tissue from endometrial surface. That would be endometrial hyperplasia, not necessarily what's happening to her. Adenomyosis is the presence of endometrial glandular tissue within the myometrium. It's common in middle-aged Paris women who have had many pregnancies. And symptoms include heavy menstrual bleeding and dysmenorrhea. This patient's endometrial biopsy result of secretory endometrium is a normal finding for a woman in day 21 of her menstrual cycle. Adenomyosis can only be diagnosed definitively by microscopic exam of a hysterectomy specimen. Right? So that's her case scenario there. This one down here is ectopic endometrial tissue. So this one down here is this endometriosis. Right? So we just did the question on the left was adenomyosis with the secretory endometrium and the whole uterus being symmetrically enlarged. Here, 28-year-old nulliparous woman comes to the clinic to be evaluated for infertility. She has been having unprotected intercourse with her husband for the past 12 months and experiences pain with deep vaginal penetration. Menarche was at age 11 and her period occurs every 26 days and lasts 5 to 7 days. Her menstrual cycles are accompanied by moderate to severe lower abdominal pain. Pelvic exam shows a normal-sized retroverted uterus. Posterior vaginal fornix is very tender to palpation. Condition was most likely... Oh, what is her condition? Okay, so with her, what are we really seeing? So she has one of the key concerning features immediately was her dyspareunia, right? The pain with sex. Other than that, most of the things are fine, and pelvic exam shows a normal-sized uterus, right? But her posterior vaginal fornix is very tender to pain. So all the way deep inside, there was tender tenderness to palpation. Since everything seems just fine for her, nothing else is really looking problematic, and she is still menstruating. So that rules out a bunch of other asteroids, right? She's still menstruating. Everything is fine. She's like a perfectly, completely normal female anatomically, except the pain with sex. And on top of that, the other major issue here is the infertility. Pain with sex and infertility, but everything else is fine. It must be endometriosis. Ectopic endometrial tissue, right? Nulliparity, early menarche, and prolonged menses are all her risk factors for endometriosis. Yeah, this was also early menarche, right? Age 11. Usually you want to see age 12 or 13. In contrast, multiparity, extended lactation, and late menarche decrease the risk due to less frequent menstrual cycles. Bleeding and shedding of extrauterine endometrium leads to formation of blood collections in the ectopic locations. Over time, the blood undergoes hemolysis and induces inflammation, which is followed by adhesion formation, which in turn distorts organ structure and function, which is why she has a retroverted uterus that you may not have really thought of as a big issue, right? But pelvic exam was a normal size. It's just that her uterus was a little kind of pulled in a different direction. The adhesions may lead to infertility, and infiltration of the posterior cul-de-sac may cause painful intercourse in dysmenorrhea. So you can see how this kind of a question, if you don't really know endometriosis very well, you'll be very confused as to what's even wrong with her. So we got adenomyosis, we got endometriosis, and here is leiomyoma. So fibroids. What's up with her? 39-year-old nulliparous woman comes to the office due to pelvic pressure and constipation that have worsened over the past year. She finds it easier to defecate while pushing the vaginal canal with her fingers to get the stool out, but still has an uncomfortable sensation of incomplete evacuation. Her menses occur every 28 days without heavy flow or severe pain. No pain with intercourse. Uses condoms routinely. BMI is fine. Examination shows an irregularly enlarged uterus and normal rectal tone. So her constipation is due to a fibroid in the back that's compressing her rectum, as I mentioned earlier, right? So it must be just leiomyoma. It cannot be one of these two case scenarios because her uterus is enlarged irregularly, which looks like this, right? So perfect, questions here. Very good way of really seeing what you're supposed to be understanding in terms of the uterine anatomy, right? Now let's take a look at the questions in CK, which are now, back there in step 1, those questions were for just understanding pathology. In CK, the same questions present, but now it's about understanding the actual diagnosis and how you would come to it, which is secondary dysmenorrhea. So this first question on the top, 19-year-old woman comes to the office due to evaluation of pain with sex. She became sexually active with her boyfriend 4 months ago, but has been avoiding intercourse for the past month because it has become too painful. She has tried using a water-based lubricant during intercourse, but it has not relieved her pain because the pain is not due to dryness. She is using condoms for contraception. She has regular menses, so that's great, right? 3 to 4 days of heavy bleeding and lower abdominal cramping. There has been an increase in cramping over the past 2 months, but no abnormal vaginal discharge. So increase in cramping is dysmenorrhea, painful cramps. She has DM1, diabetes, and uses an insulin pump. Her most recent hemoglobin A1C is 7.2%, which is a little on the higher end, but not so bad. Vitals are normal, BMI is fine. On pelvic exam, the vulva and cervix are non-inflamed. So now we're ruling out all the things. Everything should be normal. If everything's normal, then it's going to be primary dysmenorrhea. Right, so on pelvic exam, vulva and cervix are not inflamed. Speculum exam reveals a laterally displaced cervix. So her cervix is kind of pulled over to one side. That's not normal, right? Laterally displaced cervix. Bimanual exam reveals a small uterus with cervical motion tenderness. So there's pain in the cervix, which is why she's having pain with sex. What is the most likely cause of her dyspareunia? Endometriosis. As we saw, endometriosis, we could see this right here. It causes these spider webs that are then going to pull the organ into different directions, right? In our question here, this woman down here had a retroverted uterus. The uterus was pulled in, so it was kind of upside down because of the adhesions that form with endometriosis. In this patient over here, she has her cervix kind of tugged over to the laterally displaced, so either left or right. So it's tugged over to one side because of the same kinds of adhesions, which are then also causing cervical motion tenderness. It was a very straightforward, easy question. clearly pointing at endometriosis, but it was only clear and easy if you knew endometriosis, right? So hopefully now, but with the questions we've looked at, the differentials we've looked at, and the images we've looked at, it should always be clear as day to pick endometriosis. More than 45% of people should have gotten this correct. The 30% of people that chose pelvic inflammatory disease and the 10% of people that chose genital pelvic pain and penetration disorder, I can take the 10%, but the 30% that chose pelvic inflammatory disease doesn't make any sense. Right? There's no reason for you to think it's PID. Had she had gonorrhea or chlamydia some time ago and maybe she didn't treat it right, those are usually the things we look for in questions to diagnose PID. Her dyspareunia and worsening menstrual cramping most likely indicates endometriosis. These ectopic glands and stroma grow and shed within the abdominal cavity during menses. Since there is no outlet, patients develop intra-abdominal inflammation and fibrosis, leading to secondary dysmenorrhea. PID would have dyspareunia and cervical motion tenderness as well, just like her. However, she has no fever. Excuse me. She has no fever or concomitant cervicitis, making that very unlikely. And even without the fever, there's just nothing in the question that tells you she had even an STD at any point. Right? You don't just get pelvic inflammatory disease without ever having gotten gonorrhea or chlamydia, right, or any kind of infection. They didn't give you anything that was a fork in the road leading towards PID. Right? So there was no reason to really think of that. This is a very high tested topic though. The other one, GPPD, genital pelvic pain and penetration disorder. This is basically vaginismus. We've heard of vaginismus before. We just never called it GPPD. It's just pain caused by vaginal penetration only, possibly due to involuntary contraction of the pelvic floor muscles. This would not worsen menstrual cramping. It's a very benign thing that occurs in many people, completely normal, not much left to do about it. Right? You don't have to do anything about it. It's just, it will cause pain in sex, but it goes away by itself, and it's not something you can actually medically treat per se. Right? So very straightforward thing right there. This question down here is also endometriosis. So let's take a look at how this one tells us it's endometriosis. 29-year-old woman comes to the office due to infertility. Right, so you can come in for two things, as you can see. You can come in for dyspareunia, or you could come in for infertility. Both of which are things that are leading to an answer choice of endometriosis. She has had unprotected intercourse with her husband regularly for the past year and still has not become pregnant. So when that happens in any case scenario where someone's having unprotected sex, is trying to get pregnant but is not getting pregnant, what do we check for next? Well, are you menstruating? That's what we want to see next. Are you menstruating? Because if you're not menstruating, then you should be pregnant and, ACG should be there. But if you're not pregnant and you're not menstruating and, something's wrong, now we see, is it a hormonal imbalance? Is it some kind of anatomical issue? Right? Some of the things we've been looking at already. But she is menstruating. Her last menstrual period was 3 weeks ago. Her menses occur regularly. She has severe lower abdominal pain, so now we know that her menses are causing dysmenorrhea. So now we know we need to figure out, is this secondary dysmenorrhea? Because if it's not, then it must be primary. That begins the day before her menses and is only partially relieved by ibuprofen. So I'm just going to say right now though, it already is very clear that this must be secondary dysmenorrhea, because a patient with primary dysmenorrhea can easily get pregnant, right? Patients with secondary dysmenorrhea usually don't get pregnant because they have one of these issues, right? As we saw in this patient, she was 16, so the chances of her getting pregnant were there, but she wasn't really trying to, so it didn't happen, right? UWorld and STEP will do this in a very interesting way where they won't tell you that she's not pregnant, but you have to understand that she's not pregnant, especially if she is sexually active, right? I think this patient has recently become sexually active, right? So she could get pregnant. But these patients here, you can see there's a bit of an age difference here and a conceptual difference here, that both questions, they were trying to get pregnant and they're not getting pregnant. That's usually someone with secondary dysmenorrhea because of one of these other cases that are stopping them from successfully getting pregnant. So good thing to keep in mind. She was treated for gonococcal cervicitis at age 19. Boom. Now we have something that is a fork in the road that leads towards PID. She takes a prenatal vitamin daily, does not smoke, drink, or use drugs. Her husband had a normal semen analysis. So he's not the cause of infertility. Vitals are looking okay, but BMI, she's a little bit on the obese side. Exam reveals a small uterus with a cervix that appears laterally displaced. Once again, very similarly, laterally displaced, just like that. There's pain with cervical manipulation. What is the cause of infertility? Well, we know this patient has dysmenorrhea. We figured that out because they told you she has severe lower abdominal pain that begins right before her menses. So she has dysmenorrhea. Now we need to figure out why she has dysmenorrhea, and we know it's going to be some secondary cause. It's secondary dysmenorrhea. So the laterally displaced cervix that has cervical motion tenderness must mean endometriosis, where there's some spider webs, adhesions on the cervix, pulling it into one direction, preventing her from getting pregnant, and also causing a lot of pain. Her being treated for gonococcal cervicitis would be what would cause PID, which would then lead to Ashman syndrome. PID has adhesions as well. But then she was treated. And that's the main thing here, that she was actually treated. They didn't say anything's wrong with how she was treated. Right? Had they said she had some kind of STD that resolved spontaneously, well, gonococcal cervicitis does not resolve spontaneously. It might stop doing the cervicitis thing, but the gonorrhea goes upwards and causes other issues, pelvic inflammatory disease. And that's what you're going to be looking for in most questions. It's going to be somebody who had gonorrhea or chlamydia and it resolved spontaneously. They never went in for treatment, and now it's basically going to cause PID. Right? She resolved it. She treated it. So the answer was just endometriosis. But once again, we have the 30% of people that choose the wrong answer. Intrauterine adhesions. Intrauterine adhesions would not be the thing that would just pull the cervix in one direction and nothing else. Nothing else is moved. Only the cervix, right? She has severe dysmenorrhea and infertility, most likely due to endometriosis. Ectopic endometrial implants proliferate and shed with menses, and shedding occurs in the abdomen and there's no outlet, as we saw in the other explanation. So patients can develop intra-abdominal inflammation, fibrosis, and adhesions. Intra-abdominal, not intrauterine. Right? Various implant locations have different presenting symptoms, and many patients have dysmenorrhea, but seek medical attention only for infertility. That is due to impaired tubal function from chronic inflammation and pelvic adhesions, not intrauterine adhesions. Operative laparoscopy offers a diagnosis and improves fertility. Intrauterine adhesions can be due to endometritis, and there may be vaginal bleeding, but no lateral cervical displacement. Earlier, we saw septic abortion that was dealt with DNC, dilation in sharp curettage, and that can also lead to intrauterine adhesions due to Ashman syndrome, or intrauterine adhesions with endometritis from gonorrhea. But none of that is the case. Look at the endometriosis stuff. These are intra-abdominal, right? They're outside the uterus. Right? You can see the colon here. Right? So the anatomical location of the endometriosis is in the name of the condition. It's called endometriosis because the endometrium is going places outside of where it's supposed to be, right? So it goes into the abdominal area where you've seen the bladder, the colon, and the outer parts, right? You can see the ovary over here, but then endometrioma, all kinds of things. So this is the intra-abdominal thing, right? So that kind of wording always throws people off. A lot of these people that chose intrauterine adhesions probably were thinking of endometriosis and didn't really pay attention. So endometriosis, that's it for that. I don't think, is there a question? What adenomyosis as an answer? Oh, there might be one here. This actually is showing you the chocolate cyst, right? That's also endometriosis. So we'll look at this question right now. And ovarian torsion, dysmenorrhea. Oh, we got a lot of practice questions here. Okay. Before we move on to reproductive endocrinology. So when you have somebody with secondary dysmenorrhea for whatever cause, you should obtain a beta HCG test to exclude ectopic pregnancy, perform a pelvic exam to assess all these things so you can figure out whether or not it's endometriosis, adenomyosis, or fibroids. Order all the tests, of course, CBC, urinalysis, gonococcal chlamydia to find out if it's PID. Consider ultrasound to assess endometrium, uterus, and ovaries. Look for pelvic pathology that causes pain. Right? And then whatever you figure out, you treat that specific cause. Last thing here is your abnormal uterine bleeding, AUB. Before we go to that, there was this little thing here. This is also further breaking down for you the progestin challenge test. That's all it's doing. So when you do a progestin challenge test, if you take the progestin away and they have bleeding, then you need to check for LH, right? If LH is high, then the patient must have things where the LH is not working, so you're making more LH, right? If your LH is unable to cause your ovarian follicles to mature, you're going to make more LH. Or if the LH is unable to actually cause ovulation, remember there's supposed to be a LH surge to cause ovulation. If LH is not causing ovulation, you're going to keep making more LH, right? So premature menopause or PCOS. If LH is low, then it's just idiopathic anovulation. This is like one of the least tested topics, also the most extremely rare topic, but again, if it doesn't fit anything else, then this may be the answer you have to pick. If there's no withdrawal bleed, you gave progestin and you took it away and they're still not bleeding, then you need to check for FSH, right? So this is actually showing you something that follows, you know, these diagrams, we kind of hate it because this is where questions come from. It's like the question stem may have done step 1 over here, and then they got this as an answer, and then they're gonna be like, what's the next step? And you have to pick this as the next best step, not this, right? So that's going to be different answer choices. They're going to have other things to test for as well, and it can be very intimidating. So when you withdraw the progestin and there's no bleed, that usually means that you're just not having an endometrium at all, right? As we see right here, right? You take away the progesterone and there's no bleeding, it means you have no endometrium at all, which often means that you have no estrogen. And if you have no estrogen, then you need to check FSH, right? If FSH is high, but you have no estrogen, then that usually means that you have hypergonadotropic hypogonadism, aka ovarian failure, that the ovaries are just not working. But if FSH is low, then you need to do cyclic estrogen and progesterone tests, where you need to keep trying, because if FSH is low, then something is working fine, because you're not trying to override something by making more FSH, right? Something must be fine, so you try it. Basically, you keep trying it. You keep doing the progestin challenge test over and over. Cyclic estrogen progesterone test. Now if you get a withdrawal bleed, then you know that the problem is you're not making enough FSH. So you see hypogonadotropic hypogonadism, basically secondary hypogonadism. It's low because you're not making enough. There's two reasons something can be low. It can be low because there's high negative feedback, so you have a lot of estrogen that's coming back and telling you not to make FSH, or it's because you're just not making enough FSH, right? So that's what we're figuring out here. When we do this repeat, right, so step 3, we're repeating the progesterone challenge test and there's a withdrawal bleed now, then you know, okay, this person's not making enough FSH. If there's never, even after continuously repeating this, there's still no withdrawal bleed, then there's some kind of endometrial anatomic problem and you need to do a pathology test maybe, or further evaluate it even more intensely. So you want to make sure you spend a little bit of time here making sure you grasp the concepts here of why we would be checking LH or FSH, which is really just based off of the whole loop of what do they even do. We looked at it in the last video, right? What does LH cause? What is it going to be feedback inhibited by? What does FSH cause? What is it feedback inhibited by? And then it becomes logical to understand why it is the way it is. Now with abnormal uterine bleeding, normal menstrual bleeding ranges from 2 to 7 days, 7 days tops, and even 7 days is kind of pushing it. Abnormal uterine bleeding refers to alterations in quantity, duration, or frequency, and is classified by the acronym PALM-COIN. PALM refers to structural causes: polyps, adenomyosis, leiomyoma, and malignancy or hyperplasia. COIN refers to non-structural causes like coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, or not yet classified, right? So what are you going to do to figure out why somebody has abnormal bleeding? Well, first you have to see what they presented like. Assess the extent of the bleeding. Is it oligomenorrhea, where there's an increased length of time between menses, right? Maybe menses are occurring every 35 to 90 days. Polymenorrhea, too much menstruation, right? You might be menstruating twice a month, right? Because if you're having cycles that are less than 21 days, or 15-day cycles could cause you to menstruate twice a month, and that would really suck. Menorrhagia, high flow, a lot of blood, right, which will then lead to anemia. Metrorrhagia, bleeding between periods. Or menometrorrhagia, where you have excessive and irregular bleeding. You're bleeding a lot every time you menstruate, and you're bleeding in between menstruations, right? So all of these are abnormal bleeding. On pelvic exam, look for an enlarged uterus, a cervical mass, or polyps to assess for myomas, pregnancy, or cervical cancer. As usual, first thing you do, order beta HCG, rule out pregnancy. Right? One of the reasons you could be bleeding in a weird way is because of ectopic pregnancy or a pregnancy with like a molar pregnancy, something really not normal pregnancy. Do a CBC to make sure they're not completely anemic now, because if they are, you might have to give them iron supplements, maybe even blood transfusions depending on the extent of anemia. Pap smear to rule out cervical cancer. Gonorrhea chlamydia probe to rule out cervical bleeding from cervicitis, PID. TFTs and so this is thyroid function test, and prolactin to rule out hypothyroidism, prolactinemia. You want to do a platelet count, make sure they don't have a bleeding disorder like von Willebrand disease or factor 9 deficiency. Remember that factor 8 deficiency, hemophilia A and hemophilia B. Those are usually more commonly seen in men because they're X-linked, right? So here there's actually, let me just check something. Let's see. I'm not sure if both of them were X-linked. I forgot. Yeah, A and B. So you see how. Oh, that was 11. Excuse me. I read that number incorrectly. This is 11. That's what I was thinking. Like, wait a minute. Both of those are X-linked. They're usually in men, right? So hemophilia A and B are for 8 and 9. Those are X-linked, so they usually occur in men. They're saying in our question right now, or in our topic right now, to check for deficiency of factor 11, right? That would be hemophilia C, which is autosomal recessive, so it can occur in both men and women equally as possibly. But here we're talking about women, so yeah, they would have hemophilia C, if anything, right? Not hemophilia A or B. Remember when we did, if you were part of the videos or if you saw the videos, when we did our hemophilia and all the bleeding disorder questions in our step 1, and even here in CK, in those videos we talked about how some of these topics more commonly present in specific genders. Like a von Willebrand disease question usually is a female, and a hemophilia A or B question usually is a male in all questions. It's never missed. Like even here, like this question for von Willebrand disease is a woman. And if any woman is presenting with some kind of nosebleeds as a child, and typical things that we see in this question, it's female. It's never it's very, very rare. I mean, of course, von Willebrand disease can occur in a man too, but it's very rare for it to be in a man. You can see this is just an autosomal dominant condition. It can occur in men or women, but usually for step purposes, it'll be in a female. That's going to be the genetic variation to figuring out whether someone is von Willebrand disease or hemophilia, because the two things can present very similarly. So here we're checking for hemophilia C with number 11 factor deficiency. Ultrasound to look for uterine masses, PCOS, right? Thickness of the endometrium. Do the pathology test. All of this is eventually, one of these things is going to show you the root cause of the heavy bleeding. Now, how do you treat it? Well, there's a pretty intense list of things to do here, so make sure you actually understand each one pretty well. Now, if someone has acute heavy bleeding, right, then you need to give high dose estrogen to stabilize the endometrial lining and stop the bleeding. Right, this is going to be the immediate treatment for the acute problem. Transition that patient now to combined oral contraceptives or add progestin when the bleeding has stabilized. If estrogen is contraindicated for any reason, like maybe they have estrogen related breast cancer in their family history, then you can give high dose progestin therapy alone. If bleeding is not controlled within 12 to 24 hours, do a DNC. Right, clean it all out, get everything out. Ovulatory bleeding, menorrhagia, bleeding with menses, a lot of bleeding. Give NSAIDs to decrease blood loss, right? Because you want to stop that prostaglandin stuff that we just looked at when we talked about dysmenorrhea. You can give tranexamic acid, right, for 5 days during menses. If the patient is hemodynamically stable, give oral contraceptives, oral or injectable progestin, or insert a progestin IUD. Right? Progestin is the guy that's basically going to help you stop the bleeding. If you have anovulatory bleeding, which is basically the metrorrhagia, bleeding in between menses, then the goal is to convert proliferative endometrium to secretory endometrium to decrease the risk for endometrial hyperplasia and cancer. So once again, the answer is progestins for 10 days to stimulate withdrawal bleeding, combined hormonal contraception, or progestin IUD. Seems the same answer for all of them, generally speaking. And if all medical management fails, as we saw in the first case scenario with acute bleeding, DNC. And ultimately, if things are getting really bad, then they might just have to get the hysterectomy and remove the uterus, right? Women for whom hormonal treatment fails, women who no longer desire fertility, and women who have symptomatic anemia and experience disruption in their quality of life with unscheduled bleeding all over the place, all over, you could be out for work and boom, you start bleeding all of a sudden and it's not time to menstruate. These are all going to be really problematic things. So if you have these 3 bullet points, or even 2 of them that are becoming really severe, then you want to get a hysterectomy, right? And if this bullet point is there, then that's the best indication for getting a hysterectomy. If you no longer desire to get pregnant because maybe you're done getting all the kids you wanted, or whatever the cause, maybe you just never want to be pregnant, whatever the reason is, as long as the patient admits that she is not looking to ever get pregnant anymore, hysterectomy is the ultimate treatment, because if you don't have a uterus, you can't have abnormal uterine bleeding, right? So that's kind of what we're really looking at there. Here is a very simple workflow, right? Approach to postmenopausal bleeding, because here on the book itself it looks very complicated. If someone has postmenopausal bleeding, and that's one of the causes of one of the types of abnormal uterine bleeding. If someone has postmenopausal bleeding, then you want to do a transvaginal ultrasound, right? If you do the transvaginal ultrasound and you see that the endometrium is more than 4 millimeters thick, then you need to check the endometrium, do endometrial biopsy. If the endometrial biopsy has atypia, then of course surgery, because that's endometrial cancer. If the transvaginal ultrasound of the endometrium shows that the endometrium is really thin, then you just observe to see what's happening, because there's nothing else left to do there. And if you do the transvaginal ultrasound endometrium and it's really thick, but then endometrial biopsy shows nothing, then you also just observe. So you can see how you're going to be stuck between 2 answer choices, and this is usually a difficult answer choice to pick, where you're just observing, doing nothing else. But everything comes after doing the transvaginal ultrasound of the endometrium, which would be a very obvious thing if you have someone with postmenopausal bleeding. Like, you're menopausal, why are you bleeding? So let's take a look at what's happening inside. Let's look at your endometrium, right? Is it still thickening? If it's still thickening, then you need to look at the endometrium more closely with the biopsy, right? Otherwise, there's no reason for someone to be bleeding after menopause. That takes care of just one specific scenario, but generally speaking, for abnormal uterine bleeding, no matter what the type of bleeding it is, oligo, poly, menor, or metro, or whatever it is, you do the same testing for all of them. Check for reasons for bleeding, whether it's a bleeding disorder or if, making sure that they're not becoming anemic and they're going to die or something. And then you just give progestins. Progestin IUD, it should be okay. DNC if it's not working, and hysterectomy if they don't look to get pregnant. All right. So here, this is one good point also, that best initial treatment of abnormal uterine bleeding consists of NSAIDs to decrease blood loss, which we saw here. Right? NSAIDs to decrease blood loss, amenorrhea, but again, like, this may not always work. It may not always work. And oftentimes they sneak this into a question where they'll tell you that they'll be listing out all the medications the patient takes, and they'll list she takes daily NSAIDs or daily aspirin. Then obviously giving NSAIDs is not going to help her because she's already taking it and it didn't do anything. Right? So good stuff. When you look at these questions, and we will look at them at the bottom here, then you start seeing how to actually go about this case scenario of abnormal uterine bleeding. But it's always going to be the same thing as any other pathology problem. What is the problem? What's causing it? And then what is the best way of treating it? And that's all you really care about. And that's what we'll look at in our next session, where we dive into all the questions over here before moving on to the next topic.